Obesity is a chronic medical disease as defined by global health organizations, primarily since it has existing physiologic abnormalities, associated signs and symptoms that lead to related complications. Over the past 30 years, obesity has become a global pandemic. In the Philippines alone, prevalence has increased threefold. 4 in every 10 Filipinos have pre-obesity or obesity. Consequently, there is a multitude of options for managing obesity, mostly centered on lifestyle interventions. For those with the will to start on a weight loss management, majority of them experienced failure in the form of weight regain. The management of obesity has become an unmet medical need. But there is hope. Now marks a milestone in the management of obesity. With the same will to overcome obesity, there is a new way to bring forth a unique transformation. Behold, the transformation that each patient yearning for long-term weight loss has begun. The same will that patients have in fighting obesity may not be enough to battle weight regain despite best efforts. But this new way of treatment will help patients with obesity achieve the results that seem to have been so elusive due to weight regain with regimens of the past. Introducing liraglutide Saxenda. This new way presents a long-term weight loss that provides significant body weight reduction of at least 10% that was achieved by 1 out of 3 patients. That offers sustained long-term weight loss and prevention of weight regain. And it is safe to use with an established and well-characterized long-term safety profile. Obesity is now a medical disease that needs to be addressed. Liraglutide Saxenda is here to address the unmet medical needs in obesity management. Liraglutide Saxenda for a significant, sustained, and safe weight loss. With the patient's same will, liraglutide Saxenda is indeed the new way. Liraglutide Saxenda.
Transformation is the measure of achievement in the battle against obesity that liraglutide Saxenda can genuinely offer. Because the patient has the same will, liraglutide Saxenda is indeed the new way for a significant, sustained, and safe weight loss. Consequently, people with obesity tend to need a variety of tools to get them and keep them motivated. Tools that they need to effectively track their body transformation. Devices that allow them to see that they are really losing weight. Means and ways to gather suggestions on improving their lifestyle. And more so, it would be ideal if they can rely on a community that provides support to keep them motivated to stay in the health journey. Obtaining each one of these is cumbersome and complicated until now. Introducing your digital health coach that provides all these and more. Motivo. Stay motivated with Motivo. Motivo is the innovative digital app designed for people with obesity in order for them to maximize treatment outcomes through its simple yet powerful features. Education through personalized and simplified treatment initiation. progression graphs and records with milestone celebrations, sets culturally fit healthy lifestyle goals, tracks weight loss, mood, body measurements, and transformation photos, invites a buddy to motivate, coach, and support throughout the weight loss journey. With Motivo, people with obesity are given valuable benefits to stay motivated. They can maximize treatment outcomes and help them achieve their weight loss goals. They will be empowered to self manage side effects and support treatment initiations. They can get support adapting to their new lifestyle changes. Motivo can also provide healthcare practitioners an advanced tool to help manage their patients better. And all these while patients are being motivated throughout their journey of transformation. Indeed, Motivo is a dynamic, native, and intuitive mobile first user experience that complements a holistic solution to weight management. Finally, a single app for people with obesity to serve as a digital coach designed to maximize treatment outcomes is here to support people with obesity throughout their weight loss journey. They can stay motivated with Motivo.
Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, we will learn about the latest updates on obesity and how to properly advise these patients regarding their diet. This session will be presented by Dr. Florence Rochelle Gan, an endocrinologist who graduated from the University of Santo Tomas Hospital. She had her fellowship in clinical obesity and bariatric surgery in body science and metabolic disorders, International Medical Center in China Medical University Hospital in Taichung City, Taiwan. This session will be moderated by Dr. Miguel Gutierrez.
Ready, wait lang.
Okay, Doc. Pinindot ko na po yung record po, Doc, so you can start anytime po.
All right. Thank you, Kevin. So, a pleasant good morning, everyone. I am Dr. Florence Gan. Allow me to thank the organizing committee of the Tiger IM postgraduate course for this kind invitation to share with you basic concepts in obesity. Welcome to Obesity 101, a lighter look on a heavy subject. Just a disclosure, this segment received educational grant from Novo Nordisk. Obesity is a broad topic, but we will break it down into 4 smaller chunks, starting off with a discussion on the science of obesity, followed by the approach to assessing patients with obesity, then the multifaceted treatment approach to obesity, and finally, a brief look on bariatric surgery. When you hear about obesity, what comes to mind? Thoughts would dwell on excess weight, unhealthy food choices, limited physical activity, and poor health. But these are just a part of it. Traditionally, the body mass index is used as a surrogate marker of body fat and thus an objective parameter to define obesity. Studies have shown that Asian populations may have increased adiposity and cardiometabolic risk at a lower BMI. Hence, in our setting, We use the Southeast Asian BMI classification to determine risk of comorbidities. The ideal BMI is 18.5 to 22.9. A BMI of 23 to 24.9 is classified as overweight. A BMI of 25 to 29.9 is associated with moderate increase in cardiovascular risk factors in all-cause mortality and is classified as obesity class 1, while a BMI of more than or equal to 30 leaves a patient at severe risk to develop cardiovascular complications and all-cause mortality. Truly, obesity is a serious chronic progressive disease that has affected more than 600 million people around the globe. In the Philippines, the trend continues to climb, and statistics show that close to 4 out of 10 Filipinos are overweight or obese. While we are staying at home, at the comforts of our home, the obesity pandemic is now laying itself on top of the ongoing COVID-19 pandemic. We know that excess weight goes hand in hand with many other medical conditions, which by themselves make it harder to fight COVID-19. A challenge for all of us that after we curb COVID-19, we all need to work together to help curb the growing population of patients with obesity. Obesity is associated with many complications, including hypertension, dyslipidemia, heart failure, prediabetes, type 2 diabetes, dyslipidemia, osteoarthritis, polycystic ovary syndrome, and infertility in women, as well as obstructive sleep apnea. Obesity is also associated with 13 types of cancer, with strong associations with breast and colon cancers. Let's go back to the basics. Quick question. Is obesity a disease of the brain, the gut, or the adipose tissues? Let me know what you think. Feel free to write your answers in the chat box. If you also have any other questions, just write it down in our chat box. The science of obesity is quite complex but can be made simple. Let's start with the arcuate nucleus of the hypothalamus, often termed the hunger center, which controls feeding behaviors. Neurons co-expressing your agouti-related protein and neuropeptide Y in the arcuate nucleus, when activated by hormonal and neural signals from the gut, such as your ghrelin, would stimulate hunger sensation and trigger food-seeking behaviors, resulting to increased appetite. The agouti-related protein and neuropeptide Y neurons project directly to your pro-opiomelanocortin and cocaine-amphetamine regulated transcript, which suppresses food intake by increasing satiety and decreasing appetite. Leptin and insulin are two key hormones that communicate to the homeostatic system. Leptin is a fat-derived hormone, and it is secreted in proportion to the body's fat mass. Both leptin and insulin bind to their respective receptors in the arcuate nucleus to activate the POMC cart, promoting satiety and decreased appetite. GLP-1 is a powerful incretin, and peptide YY is a hormone that delays gastric emptying. Both are potent anorexigenic gut hormones that are secreted in the L cells of the small bowel in response to food ingestion. They both promote cessation or meal termination by activating the POMC neurons while reducing hunger via the agouti-related protein and your neuropeptide Y neurons. In addition, the oxyntomodulin is another peptide co-secreted with your GLP-1 and PYY. It enhances satiety and decreases food consumption. Pancreatic polypeptide is secreted in the F cells of the pancreatic islets under vagal stimulation and is released also during the postprandial phase to enhance satiety. In contrast, our ghrelin is an orexigenic hormone produced in the gastric fundus, which increases hunger and stimulates food intake. Remember that ghrelin levels rises in the fasted state and falls rapidly following your meal ingestion. So upon food ingestion, the vagal afferent fibers send signals to your nucleus tractus solitarius in the brainstem. GLP-1 and amylin also project satiety signals to the area postrema. Both your nucleus tractus solitarius and area postrema in turn integrate and transmit the signals to the homeostatic control pathways in the hypothalamus, primarily influencing satiety and meal termination. The brain plays an active role in controlling our food intake. GLP-1 and PYY, as well as oxyntomodulin, pancreatic polypeptide, and amylin all increase satiety. Conversely, ghrelin, the hunger hormone, induces feelings of hunger. Hedonic eating means that the brain can crave food, enjoy food, even when the person is completely satiated. Dopamine is released in the brain, signaling a desire to eat in response to emotional triggers such as sadness or environmental triggers such as the smell or sight of delicious food. Opioid and endocannabinoid signals are released when food is consumed and are responsible for the feeling of pleasure and associated with eating. The problem lies in some people living with obesity. They may have a heightened anticipation or wanting of the pleasure of food driven by a dysregulation of dopamine. Unfortunately, the pleasure or the liking of food is also dysfunctional and is downregulated compared to the anticipation, resulting in a need to overeat to achieve the level of anticipation. Now, this leads to a vicious cycle and can create an environment of constant overeating. But current research indicates that there is a significant crosstalk between our homeostatic and hedonic eating, which is mediated by many of our endocrine and gut related derived signals such as GLP-1. But later, we will talk about liraglutide, a GLP-1 analog, and how it helps in the fight against obesity. Third is our cognitive executive functioning, which overrides our primal eating behaviors. It works well under optimal conditions, such as when we are well rested, when we have good oxygen saturation, there is decreased stress, and when there is a strong social support. All these would help to deal with adverse situations. Through behavioral interventions, patients are empowered to have sustainable behaviors in controlling their appetite. We all know that weight loss is not easy. The physician plays a major role to also kickstart and motivate patients to go on with this lifelong journey. And this all begins with the 5 A's of management, which are ask, assess, advise, agree, and assist. First, it is important to ask for permission to discuss weight and explore patient's readiness. With permission, a start-off point could be asking how his weight is affecting his life and activities that he enjoys. On the other hand, if patient does not give permission and does not want to have a discussion about their weight, then do not push further and inform them that you are available to discuss in the future if they change their mind. Second is assessing their story. Get a comprehensive information regarding their weight and nutrition history, amount and type of physical activity, as well as limitations to do their physical activity. Is it because of pain, time, or environment, such as the COVID-19 pandemic that we have right now, that some patients are not able to go to the gym? Screen for psychological problems, addiction and abuse. Do a medication review. Ask about their sleep, family, and social history. For the physical exam, get baseline complete PE, starting off with the vital signs, height, weight, and waist circumference. Check also for signs of obesity-related complications. Note that a comprehensive history and PE will bring out the root cause of obesity. Furthermore, treating the root cause of weight is the foundation of weight management. Subsequently, ask about their goals, What kind of changes are they willing to start with? What are the reasonable goals that they would like to set regarding their weight? A review of the patient's medications and looking out for medications that can induce weight gain is very important. Remember that medication effect may vary from one patient to another, hence, the physician should assess if medication indeed contributed to increased weight. Identify, Identifying weight inducing medications and replacing with weight neutral or weight losing medications when feasible can help in weight management among patients with obesity. According to the Endocrine Society Clinical Practice Guidelines, when a clinician selects a therapy for a patient with obesity, the benefits must be weighed against the side effect, including weight gain. If the medication cannot be replaced, then consider using the lowest dose possible to elicit a response and minimize drug induced weight gain. Listed here are some medications that contribute to weight gain, and side by side are their alternative medications. The third link is advising on health risks and treatment options. This would entail a multifaceted approach, starting off with lifestyle modifications, pharmacotherapy, and a discussion on bariatric surgery. Fourth is agreeing on health outcomes and behavioral goals to create a personalized sustainable action plan. Lastly, assist the patient in accessing appropriate resources and providers. This also entails follow up, assess for progress for weight maintenance, and modify treatment approach as necessary. Personalizing the approach, recognizing patient strengths, and reframing their misconceptions about obesity are important key processes that can have a positive impact on the patient's ability to make long term changes. Now, we move on to medical management of obesity. Lifestyle therapy modifications are the cornerstone of all obesity treatment and should be the first line therapy in all individuals who are considered overweight or obese. One component of the comprehensive behavioral weight loss intervention is the frequency and duration of treatment contact. In the weight loss phase, ideally, there is weekly contact in person or by telephone for the first 5 to 6 months, which can be done in a group or individual setting. In the weight loss maintenance phase, the contact can be reduced to every other week for a year or longer. Some physicians would advocate that monthly contact is also adequate. Still, you can do this in a group or individual setting. For behavioral therapy prescription in the weight loss phase, daily monitoring of their food intake and physical activity by use of paper or electronic diaries can be done. Weight is taken weekly. A, structural, a structured curriculum of behavioral change, such as that patterned in the diabetes prevention program, can be followed. Regular feedback from an interventionist is ideal. In the weight loss maintenance phase, occasional to daily monitoring of food intake and physical activity by use of similar diaries can be done. Twice weekly to daily monitoring of weight should also be noted. The curriculum of behavioral change, including relapse, prevention, and individualized problem solving, should be emphasized. Periodic feedback from the clinician should be done. When choosing a diet, choose one that your patient will enjoy and sustain. Diet composition should be based on individual needs or preferences. Calorie restriction is the major predictor of weight loss, and substituting lower calorie healthy food that can improve the quality of the diet is important. In the weight loss phase, a hypocaloric diet wherein 1,200 to 1,500 kcal per day for those weighing less than 250 pounds and 1,500 to 1,800 kcal per day for those more than or equal to 250 pounds. The typical macronutrient composition will be less than or equal to 30% fat, with less than 7% saturated fat, with 15 to 25% of protein, and the remaining would be for carbohydrates. In the weight loss maintenance phase, it is still advocated to have a hypocaloric diet to maintain reduced body weight, and the typical macronutrient composition would still be similar to that for the weight loss maintenance phase. In the next few slides, we will be discussing intermittent fasting and the ketogenic diet. Intermittent fasting have different types. They could be alternate day fasting, modified fasting regimens, time restricted fasting, or periodic fasting. In the alternate day fasting, patients would have alternate feast and fast days. In the modified fasting regimens, severe energy restriction for 2 non-consecutive days per week, and ad libitum eating for the next or the other 5 days. In the time restricted fasting, patients would only eat during certain time periods for probably 8 hours, then fasting or remaining in the remaining hours of the day. Periodic fasting would be fasting for up to 24 hours once or twice a week with ad libitum intake on the remaining days. The Philippine Consensus Statement on the use of intermittent fasting for obese adult individuals without established ASCVD, intermittent fasting, particularly alternate day fasting, and modified fasting regimens may be used as a weight loss strategy for 6 to 12 months. Most of the studies are on alternate day fasting and modified fasting regimens, with very few studies on the time restricted feeding and periodic fasting diet. Adverse effects of intermittent fasting would include headaches, reduced energy levels, feeling cold or hypoglycemia, constipation, lightheadedness and bad breath, lack of concentration, preoccupation with food or wanting to eat food, and mood swings. On the other hand, we have ketogenic diet. There are two types. In the classical ketogenic diet, the carbohydrate content is less than 130 grams per day or less than 26% of the caloric intake by the ADA based on a 2000 kcal per day diet. In the very low carbohydrate ketogenic diet, 20 to 50 grams per day of carbohydrate is given, and there is less than 10% of the 2000 kcal per day diet consisting only of carbs, whether or not ketosis occurs. The Philippine Consensus Statement on the use of ketogenic diet states that for obese adult individuals without established ASCVD, ketogenic diet for 12 to 24 months has been shown to be associated with weight reduction. Currently, there is not enough evidence on the effect of ketogenic diet on normal weight and overweight individuals on weight reduction. Adverse effects of ketogenic diet can be short-term or long-term. Short-term effects would be constipation, headache, halitosis, muscle cramps, diarrhea, general weakness, and rash. Long-term adverse effects would be disruptions in your lipid metabolism, severe hepatic steatosis, hypoproteinemia, mineral deficiencies, increased redox imbalance, cardiomyopathy, and nephrolithiasis. For the physical activity prescription, during the weight loss phase, it is advised that patients would have a more than or equal to 180 minutes of moderate to vigorous intensity exercise for more than 3 times a week with no more than or equal to 2 consecutive days without activity. They can also opt for 2 to 3 times per week of flexibility training and balance training for older adults. 2 to 3 times per week of resistance training on non-consecutive days is also desirable. In the weight loss maintenance phase, the time spent for physical activity is increased to 200 to 300 minutes per week. Remember that the key to success is to always move. Prolonged sitting should be interrupted every 30 minutes. When lifestyle interventions are not always sufficient to maintain weight loss, pharmacological treatment should be considered as part of a comprehensive therapy. Pharmacotherapy can help patients to maintain compliance, reduce obesity related health risks, and improve their quality of life. It can also help to prevent the development of obesity related comorbidities. In the Philippines, the only available weight loss medications are orlistat, topiramate, phentermine, and liraglutide. For the purpose of this discussion, we will only be discussing orlistat and liraglutide. The indication to initiate weight loss medications are a BMI of more than or equal to 30 or more than or equal to 27, but with obesity-related complications, if lifestyle therapy does not provide sufficient clinical benefit for these individuals. Orlistat is a pancreatic lipase inhibitor. So pancreatic lipase is the primary lipase enzyme that breaks down dietary fat molecules in the human digestive system. It is one of the main digestive enzymes converting your triglycerides into monoglycerides and free fatty acids. So orlistat is a potent and selective inhibitor of pancreatic lipase, thereby inhibiting the breakdown of your dietary triglycerides into absorbable free fatty acids. As a result of this, approximately 30% of ingested triglycerides are excreted, primarily in our feces. This creates a caloric deficit. To date, orlistat is the only available obesity medication that does not specifically target appetite or satiety mechanisms. Let's discuss the SENDOS trial. It aims to know the efficacy of orlistat 120 milligrams given 3 times a day as adjunct to diet and exercise in participants with obesity or overweight without diabetes. Results show that mean weight loss after 4 years was significantly greater with orlistat at 5.8 kilograms versus 3 kilograms with placebo, and this is statistically significant. Looking into the secondary efficacy results in the SENDOS trial, treatment with orlistat plus lifestyle changes resulted in early and significant improvements in cardiovascular risk factors that were sustained throughout the study, including blood pressure, waist circumference, and your lipids. Orlistat therapy is associated with significant adverse gastrointestinal effects, including oily spotting in stool, flatulence with discharge, fecal urgency, and frequent bowel movement. These adverse events may cause patients who do not lower their dietary fat intake to discontinue orlistat therapy. A few reminders on orlistat use. It may result to decreased absorption of your fat-soluble vitamins, and there were rare cases of severe liver injury or acute liver failure. Contraindications to the use of orlistat would be pregnancy, chronic malabsorption, cholestasis, and oxalate nephropathy. Another medication that has been shown to be efficacious in weight loss management is liraglutide. Here, we can see that the amino acid structure of liraglutide, a human GLP-1 analog, side by side with its native GLP-1. In plasma, native GLP-1 is rapidly degraded by your enzyme dipeptidyl peptidase 4, making it unsuitable for clinical use. Liraglutide shares 97% amino acid homology to human GLP-1, and it has been modified to extend the half-life from 2 minutes to 13 hours. In this study, it shows that liraglutide, a GLP-1 analog, stimulates anorexigenic neurons and inhibits orexigenic neurons. Liraglutide-treated subjects, represented by your dark blue bars, reported significantly increased feelings of satiety and fullness compared with subjects treated with placebo, represented by your gray bars. Reduced feelings of hunger as well as prospective food consumption. Let's now discuss the 56-week scale obesity and prediabetes trial. It is a randomized, double-blind, placebo-controlled, multicenter trial, and it enrolled adults with obesity and those with overweight, with comorbidities but without diabetes. Study participants were randomized in a 2:1 fashion to receive liraglutide 3 milligrams or placebo. They were stratified according to prediabetes status at baseline. At 56 weeks, participants without prediabetes who were receiving liraglutide 3 milligrams were re-randomized in a 1:1 fashion to either continue liraglutide 3 milligrams or to receive placebo for the next 12 weeks. From this, we can see that at 56 weeks, treatment with liraglutide 3 milligrams led to a statistically significant greater weight loss of 8% compared with 2.6% with placebo. The mean fasting body weight loss for individuals who completed the last visit was 9.2% in the liraglutide-treated study arm compared with 3.5% in the placebo-treated study arm. Notable that it was weight loss that was most rapid in the first 16 weeks and slowly over 16 to 40 weeks, with the nadir occurring at 40 to 48 weeks. Weight loss with liraglutide 3 milligrams was maintained throughout the duration of this trial. This graph shows the change in body weight by prediabetes status. In participants without prediabetes, at week 56, treatment with liraglutide 3 milligrams led to a statistically significant greater weight loss of 7.9% compared with 2.7% with placebo. As we can see, weight loss in participants with prediabetes was also very similar, 8% versus 2.6% respectively. This graph just goes to show that weight loss with liraglutide 3 milligrams was maintained over the duration of the trial, irrespective of their prediabetes status. Furthermore, at week 56, the proportion of individuals achieving more than or equal to 5%, more than 10%, and more than 15% was significantly greater with liraglutide 3 milligrams as represented by your blue bars when compared with placebo represented by your gray bars. As shown by the top two graphs, liraglutide improved blood pressure at week 56 compared with placebo. Systolic blood pressure was significantly reduced by 4.2 millimeters mercury with liraglutide 3 milligrams when compared with 1.5 millimeters mercury with placebo. Diastolic blood pressure was significantly reduced by 2.6 millimeters mercury with liraglutide 3 milligrams when compared with 1.9 millimeters mercury with placebo. The bottom graph illustrates the changes in pulse over the trial. Compared with placebo, pulse increased with liraglutide 3 milligrams during the first 2 weeks of treatment and during the first 2 weeks of treatment, but this remained elevated during the treatment with liraglutide 3 milligrams. Significant improvements were also noted in all of the fasting lipids at week 56 with liraglutide 3 milligrams when compared with placebo. The impact of weight on quality of life, light, is a 100-point scale questionnaire designed to quantitatively assess an individual's perception of how their weight affects their day-to-day activities. At week 56, it is notable that liraglutide 3 milligrams was associated with statistically significant improvements compared with placebo across all domains such as physical function, self esteem, sexual life, public distress, and work. This also stands true for their total score. Consistent with the known safety profile of liraglutide 1.8 milligrams for the treatment of type 2 diabetes, the most common adverse events that were reported with liraglutide 3 milligrams were gastrointestinal related, such as your nausea, diarrhea, constipation, vomiting, decreased appetite, and dyspepsia. And these occurred at a higher frequency when compared to placebo. Hypoglycemia adverse events were recorded for 11.9% of patients in the liraglutide group and 3.3% in the placebo group. All these events were a result of the biochemical measurements taken during the oral glucose tolerance test or visits for fasting plasma glucose measurement. No events were serious or required third-party assistance. From this graph, we can see that nausea was most prominent, and it is the common adverse event with liraglutide 3 milligrams. However, it was generally transient and occurred primarily in the first 4 to 8 weeks after starting liraglutide. After this time, instances of nausea leveled off to a background of around 5.5%. The frequency of gallbladder-related adverse events were higher with liraglutide 3 milligrams than placebo. With regard to pancreatitis, there were 11 confirmed cases, 10 in 2,481 patients, or 0.4% in the liraglutide group, of which 9 were mild in severity. And there was 1 in 1,242 patients, or 0.1% in the placebo group. To summarize, in the 56-week scale obesity and prediabetes trial, liraglutide 3 milligrams once daily was associated with clinically meaningful weight loss in individuals with obesity or overweight with comorbidities, as well as improvements in their glycemic endpoints, cardiometabolic risk factors, and quality of life. There were no significant new safety signals, with gastrointestinal events being the most commonly reported adverse events. Now, this slide summarizes the key safety issues with liraglutide 3 milligrams identified during the scale trials. So, across all the scale trials, gastrointestinal adverse events were the most commonly reported with liraglutide 3 milligrams. Overall incidence of acute pancreatitis was low, but was higher with liraglutide 3 milligrams than with placebo. They were generally uncomplicated, and there were no cases of necrotizing or hemorrhagic pancreatitis that was reported. In the scale obesity and prediabetes trial that lasted for 3 years, 10 cases of breast cancer were reported. Approximately half of these were screened detected, and liraglutide treated women with events of breast neoplasms generally had a bias in detection compared with placebo. Based on this low number of events, in the short interval between study entry and diagnosis, and absence of a signal for increased risk from the extensive clinical experience with GLP-1 receptor agonists in type 2 diabetes, there is insufficient evidence to support a causal link to liraglutide. Next is medullary thyroid cancer. A rare case of thyroid cancer has been observed with liraglutide in rodent studies. However, rodents have higher numbers of C cells, which are sensitive to GLP-1, while humans have far fewer and no detectable effect from GLP-1. In the SCALE program, no individuals treated with liraglutide developed C cell cancer. In the SCALE obesity and prediabetes trial that also lasted for 3 years, we can also note that treatment with liraglutide 3 milligrams was not associated with excess cardiovascular risk. There were also no imbalances between treatment were observed in anxiety or depression based on adverse event reporting on mental health questionnaires. In general, regulatory agencies recommend discontinuing any type of pharmacotherapy for obesity if weight loss of more than or equal to 5% has not been achieved after 3 months on the therapeutic dose. So both the EMA and FDA have included stopping rules within the product label for liraglutide 3 milligrams to define patients who should discontinue therapy due to insufficient efficiency. If clinically significant weight loss is not achieved with pharmacotherapy, other factors contributing to perceived pharmacotherapy failure should be assessed, and these include inappropriate dosing or adherence, barriers to health behavioral changes, psychosocial issues, as well as medical issues. Consideration should also be given to trying another obesity medication or obesity management therapy if clinically significant obesity management success has not been achieved after 3 months on the full maximum tolerated dose and no other evident etiologies of the lack of success are apparent. Currently, we are not able to predict which medication will benefit a patient most. With the evolution of precision medicine, including hormonal and genetic profiling, it may be in the future possible to predict which pharmacotherapy may benefit an individual patient the most. Next, let's discuss bariatric endoscopy. Bariatric endoscopy is an evolving field generated to combat the epidemic of obesity through minimally invasive techniques. These procedures can be done in an ambulatory setting and are potentially reversible, repeatable, and pose less complications than their invasive surgical counterparts. There are more than a handful of procedures, but we will only discuss the ones that are available or might be available in our setting. Available in the Philippines is the Obera intragastric balloon, wherein an elastic spherical balloon made from silicone is filled with about 500 to 700 ml of saline, and it is inserted and retrieved endoscopically. Soon, the reshaped duo might be available, which is a dual intragastric balloon system. Soon to come also, maybe in our country, is the Aspire and endoscopic sleeve gastroplasty. The Aspire device is like your peg. 2 weeks after the insertion, the external portion of this device is connected to a valve wherein it allows aspiration of 30% of the ingested meal 20 minutes after ingesting it. The endoscopic sleeve gastroplasty is like doing a sleeve gastrectomy without cutting it. It reduces the entire stomach along the greater curvature, creating an endoscopically created sleeve. This table summarizes the indication, duration, efficacy, advantages, and disadvantages of the intragastric balloon, the Aspire Assist, as well as the endoscopic. Our intragastric balloon is indicated for those with BMI of 30 to 40 for the duration of 6 months, and after 6 months, we have to take it out. About 7% to 15% of the total body weight is lost. What's good with it is reversible, repeatable, and can be used in conjunction with other procedures. The disadvantage is that there is a high risk for nausea and vomiting, and there are rare reported cases of gastric perforation. In the Aspire Assist, it is indicated if the BMI is around 35 to 55. It can be placed long term. There is a 14 to 18% total body weight loss. The good thing with it is that it can be used long term and it's effective with minimal side effect. However, patients should have frequent checkups with their doctor. There could be abdominal pain and peristomal complications. Lastly, the endoscopic sleeve is done among patients who have a BMI of 30 to 40. Long-term follow-up studies is in progress since this is just a new technique. 12 to 19% of total body weight is lost. It is minimally invasive, and this needs skill to be done. Perigastric fluid collection and extragastric bleeding can occur. We are now at the last leg of the discussion. There are different types of bariatric procedures worldwide, but the four most common are gastric banding, sleeve gastrectomy, Roux-en-Y gastric bypass, and biliopancreatic diversion with duodenal switch. In the Philippines, what we usually do is the sleeve gastrectomy and Roux-en-Y gastric bypass. Gastric banding is not anymore done nowadays. A band is usually a silicone band that is wrapped around the upper part of the stomach to create a smaller stomach. Small quantities of food can fill up the small stomach, providing early satiety. In sleeve gastrectomy, a part of the stomach is removed, making the stomach smaller, and this results to roughly the size and shape of a banana or a sleeve. In Roux-en-Y gastric bypass, a small pouch on the top of the stomach is created by stapling the stomach that holds less food, around 30 cc, and then reshaping it to a portion of the small intestine into a Y. The Y portion of the intestine is then connected to the stomach pouch so that food can travel directly into the lower part of the small intestine. Thus, it bypasses the duodenum as well as the jejunum. Bypassing these sections of the small intestines restricts the amount of calories and nutrients that are absorbed into the body. The biliopancreatic diversion with duodenal switch is a procedure wherein a small pouch is also created by removing a portion of the stomach, and later a portion of the small intestine is bypassed, quite similar to the Roux-en-Y gastric bypass. Subsequently, a duodenal switch is done. This is a very malabsorptive procedure and not usually done in our setting. The indications for bariatric surgery are as follows: a BMI of more than or equal to 40, a BMI of more than or equal to 35, with more than or one obesity-related comorbidities, or a BMI of 30 to 34.9, and type 2 diabetes with inadequate glycemic control despite optimal lifestyle and medical therapy. BMI in this criterion for bariatric procedures should be adjusted based on ethnicity. To date, bariatric surgery has shown the most dramatic results in the treatment of obesity, and current literature has shown that this treatment can be lasting and effective with improvement of obesity-related comorbidities. Despite these advantages, bariatric surgery poses several disadvantages, and as with all procedures, bariatric surgery comes with possible complications. So for gastric banding, there is a 20 to 25% total weight loss. Generally, there is no anatomic alteration. It's removable and adjustable. But there is high recidivism with gastric banding. There's a risk for erosion and a risk also of slip the band. In sleeve gastrectomy, there is 25 to 30% total weight loss. It is easy to perform. There is no anastomosis. It is reproducible. There are few long-term complications with many metabolic effects. Leaks are with sleeve gastrectomy depending on the skill of the bariatric surgeon, and some might be hard to manage. Sleeve gastrectomy also results to 20 to 30% of GERD. In Roux-en-Y gastric bypass, there is 30 to 35% of total weight loss. There is strong metabolic effects. This technique has been standardized. It is very effective for GERD. It can be used as a second stage treatment after sleeve gastrectomy. However, there are few revisional options for weight gain if they had undergone Roux-en-Y gastric bypass. Risk of marginal ulcers are there. Internal hernias also occur, and micronutrient deficiencies should be checked among patients who underwent Roux-en-Y gastric bypass. Lastly, in BPDDS, the percent total weight loss is around 35 to 45%. It has very strong metabolic effects. It has durable weight loss. It is effective for patients with very high BMI, especially those in the super obese category. It can also be used as a second stage for sleeve gastrectomy. On the other hand, unfavorable aspects would be it is very malabsorptive. It has very high rate of micronutrient deficiencies. There are 3 to 5% of protein malnutrition. There is a risk for GERD, internal hernias, duodenal dissection, and it is technically challenging. As mentioned, more commonly done in the Philippines nowadays would be your Roux-en-Y gastric bypass, sleeve gastrectomy, or sleeve plus procedures. We should remember that bariatric care does not end after the patient undergoes the surgery, but it is a lifelong journey with the patient. I hope that together both physicians and surgeons can work together hand in hand to win the fight against obesity. In summary, the biological control of appetite is complex and involves the integration of the central neural circuits with signals from the gut and adipose tissues, as well as other organs. Many peripheral signals can act directly on the neuropeptide Y and a gouty related protein, as well as your CART and POMC neurons to promote particular appetite sensations via their effects on second order neurons such as your ghrelin, leptin, and GLP-1. We have GLP-1 receptor agonists in the market, and obesity researches are underway that focuses on different gut hormones such as your oxytocin, amylin, and PYY. It is anticipated that administering combinations of these hormones will be beneficial to address the highly redundant hormonal physiology that defines body weight. And this is something we can all look forward to. Remember the 5 A's in the approach to management of obesity, which is ask, assess, advise, agree, and assist. We also have discussed the components of a comprehensive behavioral weight loss intervention that will achieve a 7 to 10% weight loss. There are plenty weight loss programs, but despite predictor of success, we know that dietary adherence is the best predictor of the success. This does not mean that diet composition is not important, but merely that negative energy balance is the key factor in promoting weight loss. If indicated, medications like orlistat and liraglutide can also help as add-on therapy to achieve goals. Allow me to highlight key results in the 56-week scale obesity and prediabetes trial that showed that liraglutide 3 milligrams once daily was associated with clinically meaningful weight loss in individuals with obesity or overweight with comorbidities, as well as improvements in their glycemic endpoints, cardiometabolic risk factors, and quality of life. There were no significant new safety signals besides the gastrointestinal events being the most commonly reported adverse events. We have touched lightly on bariatric endoscopy and bariatric surgery, and these are also weight management options that we can consider. Close follow-up and monitoring should be done among these patients. Lastly, there is no one-size-fits-all in obesity management. A combination of lifestyle change and behavioral treatment, pharmacotherapy, endoscopic and surgical interventions can be offered to provide personalized care. As physicians, we play a major role in the life of our patients. At the end of the day, looking beyond the numbers lost, we move to a paradigm shift that focuses on the importance of improving patient centered health outcomes. Let me end by saying the roots of obesity run deep, but together, let us all join hands and work together to create a healthier and brighter future. Thank you for your kind attention.
For the highlight of this postgraduate course, let us be inspired as we hear from Dr. Bong Javier. Please proceed to www.tiktok2021.com and click on the Distinguished Alumnus Lecture in the Plenary Session tab.